This presentation was prepared as part of the HAP 709 course on Health Database taught by Farrokh Alemi, PhD at George Mason University, Department of Health Administration and Policy. Undiagnosed diabetes and prediabetes present a serious public health challenge. Prediabetes is much more prevalent than frank diabetes, affecting 84 million people in the United States. It has been described as a silent precursor. It put people at high risk for type 2 diabetes and for vascular disease, and according to the CDC estimates, 88% of those with prediabetes remain undiagnosed. It is estimated that almost a quarter of those with diabetes in the United States, a staggering 7.2 million individuals, are not aware of the condition, and almost half of those with diagnosed diabetes do not achieve optimal glycemic control. The data available in the healthcare settings can serve as a tool for early dyslipidemia. In this presentation, I sought to determine how the identification approach can be recalibrated to detect diabetes or prediabetes using integrated electronic health records. The best performance of detecting diabetes was achieved by a model that took advantage of the AHR predictors, including age, sex, race, ethnicity, overweight, obesity, hypertension, hyperlipidemia, and smoking status from the medical EHR. Across a range of populations informed by patient characteristics, healthcare members can play a role in helping to identify patients with undiagnosed diabetes or prediabetes. The accuracy of prediction increases when present findings are combined with information from the medical EHR. The source and size of the data comprises patients who were diagnosed with diabetes listed under the ICD-9 column. For example, I249, I250, and I250. After the data was cleaned, removing repeats and null values, it contained 73,966 patients listed. When it comes to identifying diabetes mellitus in ICD-9 CM, coders identify whether the diabetes is type 1 or type 2 using a fifth digit. If the diabetes is secondary, coders choose from codes in the 249 series. The data comprises patients who were diagnosed with diabetes listed under ICD-9 column. For example, I249, I250, and I250.01. So we have 16 diagnoses to predict the presence of diabetes. The total number of diagnoses which has at least 9 observations are the 29. So that the query that I have shown, I have identified age through age at first DM. The gender part was not able to identify from the current data. These are the diagnoses that occur more than 29 times and are the rarest. This is the data that has the 10 most predictive diagnoses that are not obvious. This particular query is giving you the ICD-9s, what the particular count is for those diagnoses. So let's say how many rows for a particular diagnosis, and that is a frequency for one diagnosis. So what this is now giving you is the diagnosis, a patient, a age at diagnosis, and then the total number of counts for that given diagnosis. So this is how to calculate a frequency table. The frequency table is followed by essentially what naive Bayes is. What the code states is the probability of having an illness if your age is greater than 70 is listed in this data set, and that is 10 over 15 people equaling 0.67. Probability of having an illness is 1, and the probability that you are greater than 70 is 0.67. Naive Bayes is used to identify greater than 70 and having an illness. Input the values and you will get 1. one meaning you have a high probability of getting an illness and greater than 70. Naive Bayes is getting the probability of something happening given that another thing has already happened. In cross-validation, 80% of my data was split into the training data set and 20% of it was split into validation set. So that is how I've done this. Predictors that occur after diabetes is part of my cleanup process. So you would see that I have removed patients whose age at DX is null. In conclusion, I believe the proper screening will include gathering information such as family history, the actual age of patient, occupation of patient. Occupation of patient is a great factor since individuals have more labor-intense occupations. The data, in my opinion, is fairly limited. One thing that is great about this data, though, is the vast information with huge number of rows, but limited number of attributes.